We are live.
Good evening, everyone. Welcome to iFocus Online, Lecture 153 and Retina Session 5. Today we have with us Dr. Vinod Kumar sir, and he'll be talking on standard fundus photography, wide field and ultra wide field imaging, autofluorescence, and multicolor imaging. I request Dr. Lalit Verma sir to please introduce him.
Good evening, everyone, and welcome to this iFocus unique lecture series, where I was just discussing that aim is to teach. Aim is to teach so that the audience learns something about it. So we'll be very happy. The iFocus team, entire iFocus team works very hard because aim is not just to lecture, aim is to teach. And if there are any questions which you are unable to cover, please mail them to Santosh or Rolika or to us so that we can take it up, because we are very rigid about the time, start 8 and finish at 9 o'clock. And as has been the theme of this iFocus, that we start with basics, and we have already covered 4 such talks in basics. We have covered applied anatomy, we have covered applied physiology and history taking, then indirect fundoscopy. Now, after all this, you want to show anatomy, physiology, history taking, indirect. Next comes obviously the imaging. You see, after we have a preliminary workup, so the ophthalmologist or the retinologist, then he has a recourse to imaging. And imaging, believe me, multimodal imaging, as we call it, has taken the world by storm. Without that, it's virtually very difficult to practice nowadays retina. And as we say, indirect ophthalmoscopy and OCT, these are the 2 things which form the hallmark. So here we have with us Dr. Vinod. He is an additional professor at the Apex Institute, that is RP Center. And he is a graduate and postgraduate from Mount Maulana Azhar Middle College. And at his young age, he has remembered more than 200 index publications. And he has described a couple of novel signs, which we'll come to know, and has been author of Handbook of Clinical Trials in Ophthalmology and a lot of book chapters and huge number of presentations at this young age. So we are very proud to have Dr. Vinod. One thing I like about Vinod is his crystal clear concepts till the basics. And that is the reason we have him here and the iFocus. He will try to explain about imaging, what is standard photography, what is wide field, which is catching up, and multi-color imaging. So over to you, Vinod, and you have around 40 minutes with you. So, and after that, we'll have some questions from the hot seat participants as well as the audience. So over to you,
Vinod. Thank you so much, sir. I hope my slides are visible.
Yeah.
I am audible.
Yes.
Thank you once again, Dr. Lalit sir, for your kind words. And many thanks to Dr. Honavar sir for giving me this opportunity to reach every one of you. So I'll straightway start my talk, which is about the standard fundus photography, wide field as well as ultra wide field imaging. So now, just to be a brief introduction, the classical way of practicing medicine is that we examine the patient, we take history, then we suspect a disease and diagnose a particular patient with particular diagnosis. Then we do investigations to confirm our diagnosis, and then we treat that particular patient. But one of the hallmarks of modern day medicine practice is that we document. That is the hallmark of modern day medicine. It is important from several points of view because it is important for teaching to the residents as well as the medical students. It is very important for patient education. We have to educate the patient at the same time to explain him the things which are going on. And then when we treat such patients, it's helpful in the follow-up, how the disease has changed. It is very, very important from medical legal point of view, which is the need of the hour. I think more and more of us are facing these medical legal issues. And documentation is the sole thing which stands between us and the vindication. Then coming to disease itself, the documentation helps us in better understanding of the disease, and makes the backbone of the research, which is ultimate aim of betterment of human being. Now, the classical way of documentation has been color diagrams, but remember, we have all made these diagrams. These are subjective. Not all details can be mentioned on these color diagrams, though important ones we try to note down. It is time consuming and depends upon the skill of the drawer also. And last but not the least, it is very important that we will draw only what we know. And remember, we'll see only those things we know. So the things which we are not able to see will not be drawing. Color photograph, which we routinely take, also known as the standard color photographs, are the objective way of evaluating the fundus and also documenting it. It is not dependent on the observer. We can always go back to the first documentation and re-verify our findings. It is less time consuming, but of course it comes at a price that includes additional personnel and we need more equipment. Now, just to give you a small example, this is a patient I came across many years back, and I don't know what was the diagnosis. If I wouldn't have the fundus photograph, probably I would have never reached the diagnosis. Now, if you see there is an abnormal vessel going through the fovea, probably at first visit, I wouldn't have known the diagnosis. And if I wouldn't know there is a vessel, I wouldn't have drawn it. But because I had taken a photograph, I remembered that there was an abnormal vessel which is going through the fovea, and therefore I could check this diagnosis with my seniors, which I later came to know that this is nothing but a congenital retinal macrovessel and is a normal physiological variation. Now, coming to standard fundus photography, as we all know, it captures around 30 to 45 degrees of field of retina. Now, initially we used to use analog cameras, but over the years, we've shifted onto the digital cameras. And now with the help of digital cameras, we can get high resolution and high magnification images of almost everywhere in the retina. But all we need to do is keep shifting the gaze of the patient to various directions, and then we can capture the various areas of the retina. Now, if you remember, if you see, I've written over here standard photography versus conventional. Now, standard, as we can say, is something which keeps on changing. What could be standard today may not be standard tomorrow. So 30 to 45 degrees, maybe it was a standard 1 decade ago, but nowadays, especially in institutional practice, I would say, I would rather call it as a conventional way of fundus photography, because most of our photography nowadays is wide field and ultra wide field. Using these kind of fundus cameras, which we have at RP Center, we have Zeiss as well as Topcon one. We can acquire color photographs, autofluorescence, fundus fluorescent angiography, and ICG. Now, this all of you have must heard about, but what is not very commonly talked about is the filters. Now, these cameras would have some kind of filters which come in various colors, red, green, and blue. And it is very important that you know, because each one of these gives us very important piece of information. Now, I've tried to keep few of the common type of pictures we get in our clinics. This is how standard color photograph of a normal person would look like. And if you see the top 3, and on your left, this one is from Topcon, and in the right eye, the picture on the lower hand side, right one, is the color fundus photograph from a Zeiss camera. Now, if you see, these gives you beautiful depiction of the disc as well as the macula, and you can capture various abnormalities. For example, the disc melanocytoma over here, the morning disc glory over here, and a common condition called BRVO, supratemporal BRVO over here. Now, this is the color fundus photograph. I'll show you what is the utility of various filters. Now, have a look at this particular fundus. If you see, more or less, it looks normal apart from tessellated fundus, and you can see various choroidal vessels, large, which are prominently visible. Now, if you carefully see over here, there appears the reddish lesion. And if you can make out, there is something over here. Now, I go to the autofluorescence image of this particular patient, and by and large, it is normal. We do a fundus fluorescein angiography. Again, it does not tell us very much apart from that particular large lesion over the macular area is little hyperfluorescent, the localized more hyperfluorescence over this lesion. Now, see very carefully what happens when we take a photograph with red filter, or green filter, also known as red-free photograph. Now, red-free photograph is very important to capture the details of the retina. And if you see, the moment we take a picture with red-free photograph or green filter, we see that the macular hole, which was overlying that red lesion over this whole area, becomes prominent. And then we go to green-free filter, that is a red filter. This is very important for seeing the choroidal vessels. Now you see the macular hole just disappears, and all we can see is very prominent choroidal vasculature. And see the beauty that without any angiography, you can see the details of the retina as well as the choroidal vasculature. So that is the importance of various filters, which are there in most of the fundus cameras. And without being invasive, we can use these filters to give us the various details of the retina and the choroid. And when we do the OCT, we could see there was a choroidal mound in the beneath the macula, and there was a full thickness macular hole overlying it. So basically, this patient had a circumscribed choroidal hemangioma with overlying full thickness macular hole. So you see, not one photograph gives you everything, but if you use filters, it highlights the various properties of the retina and choroid, and you can easily make the diagnosis. So I have written it over here. So red-free photographs typically use green filter, and it is used for retina, seeing the details of the retina and retinal vessels. This is one such photograph. You can see this is a patient with PDR. Sometimes you will not be able to see any neovascularization, but moment you go to red-free photographs or green photographs with green filter, these new vessels which are there over the surface of the retina, they become prominent. The green-free filter is used for choroidal vessels, and we have something called as blue-free filter, where blue-free photographs where we use a yellow filter. It is useful for the surface, retinal surface. Some lesions, for example, dissociated optic nerve fiber layer, are particularly well seen with blue-free photographs. So this is one such patient. If you see, this is a fundus photograph of an elderly female. You can see some dots over there, over the retina in the macular area, which are more in the superior macula. But once we go to red-free photographs, you can see many more such dots are visible, and these are nothing but nodular form of reticular pseudodrusen. And this again highlights the fact how use of certain simple filters can augment the various lesions in the retina and help us reach a diagnosis. Now, this is a patient, as I told you, this is a patient, you can see these linear spindle-shaped lesions which are scattered all over the macula. This is a patient who has undergone ILM peeling, and this is what is known as dissociated optic nerve fiber layer, and can be very easily seen with blue-free images. So to summarize, traditional fundus camera captures up to 30 to 40 degrees of visual field. But the problem was we were not able to see beyond the arcades. So the first concept of imaging beyond traditional or conventional was given by ETDR study in 1991, where they combined 7 standard fields. So what they did is they captured 7 photographs centered around the posterior pole, and then they made a collage of it, and we could get these pictures which are known as montages. So with the help of 7 standard fields, we could image around 75 degrees of retina. However, the problem with these images is that the patient must have a good visual fixation and patient must be very cooperative to obtain these images in various directions. This can be time consuming and especially problematic where in the centers which are high volume centers. And since a good patient cooperation is required, it is also important that patient has a good vision so that he can fixate in various directions. Over a period of time, we became good over these montage making, and some machines even had the benefit of automated image montages where we could take the images and the machine will automatically automatically create these montages where we could see the more amount of retina. Remember, in ETDRS, it was 7 number of fields, but over a period of time, we became more proficient. We were able to join even more than 7 fields to give us the capture of the field which we were more interested in. Again, have a look at this image. You can see we have created a montage of various pictures which have been taken at the posterior pole. And since there was main pathology in the temporal retina, we have taken an additional photograph of the temporal retina, which shows you various bulb-like dilatations, which is nothing but Coats disease, which is leading to exudation at the posterior pole. And you can see how beautifully we can depict the whole disease. But problem is, again, you have to have a very cooperative patient, and we may not be able to capture whole of the retina. This is again an example of a patient who had a central retinal vein occlusion along with a cilioretinal artery occlusion. And you can see a very nice montage. But again, you see, because each image has its artifacts, it does not give us a very good overall view of the retina. So problem with these montage images was that large part of the retina still could not be imaged, and most of the peripheral lesions we could document only with the help of drawings. So there the concept of wide field and ultra wide field imaging came. In fact, these terms became clinically useful only later on. Actually, the technology came before these terms. Until recent, these terms, that is wide field and ultra wide field imaging, were used very loosely and interchangeably. And there was no strict definition until DRCR.net described that any picture which consists of 100 degrees of retinal field can be called as wide field or ultra wide field. But again, it remained ambiguous as to what was wide field imaging and what was ultra wide field imaging. So very recently, around a year back, in Ophthalmology Retina, a consensus was published whereby most of the imaging specialists agreed that anything which imaged up to the vascular arcades is conventional photography and consists of 50 degrees of field. Anything which captures posterior to the vertex vein ampulla would be called as wide field, and anything which captures simultaneously all 4 vertex vein ampulla will be called as ultra wide field. But remember, all this has to be in a single click. So if you are doing multiple clicks and doing montage, then it will not be candidate for wide field or ultra wide field imaging. Okay, and panretinal, which we still have not been able to do, would be the imaging of the entire retina in a single click. Over the period of time, we have the technology has advanced immensely, and nowadays we have several commercially available fundus cameras which can capture various amounts of retina. Now, ETDRS we have already talked about, it captures around 75 degrees of retina. RetCam has been available with us, but the problem is that it is predominantly a contact system where the patient's cornea is touched. Therefore, it is used mainly in the pediatric eyes, especially in ROP. We have a Heidelberg system, which has been available for quite some time. But again, non-contact module of the Heidelberg Spectralis captures only 110 degrees. If you have to capture more areas, area that is 150 degree. There is a special lens called Storangi lens, and again it becomes a contact procedure. Now, what came into the commercially available market is Optos imaging system around a decade back. And I think this is something which has been used widely. And this is something I have most personal experience with. And this is the system gives the widest view of the retina in a single click. Subsequently, Zeiss came up with a wide field system called Clarus, and Nidec came out recently with a system called Mirante. Now, each of these has a maximum field of view, but remember, as I told you, Opto is something gives us the widest view in a single click. Now, this is the table I've tried to compile for you, which basically indicates what kind of imaging modalities are available in each of these. But remember, most of these systems come with inherent capability of doing fluorescein angiography, ICG angiography, autofluorescence, and most of the modern systems also have inbuilt optical coherence tomography. So basically, you don't need any other machine. With a single machine, you will be able to capture almost all kinds of images with a particular image. But the most important difference again between all these machines is that kind of colored images they take. Remember, Clarus, the one by Zeiss, is the only one which takes the true color images. Most of the other machines take pseudo color images, and what are those? We'll come to them shortly. Now, as I told you, I have most experience with Optos, so I'll be mainly concentrating about ultrawide field imaging using ultrawide Optos. Most of these, again, ultrawide field systems are based on confocal scanning laser ophthalmoscopy. Optos uses a virtual point technology and provides us high resolution images of approximately 200 degrees of retina using two lasers, that is red and green. And as I told you, they can provide us ultra wide field ICGA also. This is kind of photograph which we get typically with Optos. You see there are no true colors, only red and green colors. And that's why these images are known as pseudo color images. This is how a wide field fluorescein angiography would look like, wide field autofluorescence. And this is what I was talking about, where you can see all the 4 vortex vein ampulla, that too in a single click, that would be known as ultra wide field imaging. Now, what is the utility of ultra wide field imaging? I think the most common disorders are retinal vascular disorders. So we'll talk about them first. Now, this is a case I like to show, I think almost all the meeting. See, this is a middle-aged male, 45 male, who came to us with diagnosis of neovascular glaucoma. If you see carefully, there is almost total glaucomatous optic atrophy. This, you can see the laser spot. And if you see carefully, there are some cryo spots as well. So one would wonder why, in spite of such laser and cryo spots, this patient went on to develop neovascularization. So when we do a ultra-wide field fluorescein angiography, you can see there are large areas of capillary non-perfusion which have not been covered. And that is why, in spite of laser photocoagulation, this patient went on to develop neovascular glaucoma. Now have a look at the other eye of this patient. This is a conventional photography. You can see the images are not very clear because the patient had some amount of cataract. We do a normal fluorescein angiogram using a standard camera. Again, you can see some CNP areas and capillary non-perfusion at the fovea. But once we go on to ultra-wide field imaging, you can see this patient had undergone peripheral laser photocoagulation. And you can see on ultra-wide field FFA, there are large uncovered spaces which are still present in this particular patient. And if we do not cover all these capillary non-perfusion area, probably this eye is going to meet the same fate as of the other eye. Again, just to give you an example, but we see in an ultra-wide field imaging, this is what a normal conventional angiography is going to show you. High risk PDR, large NVD and NB, capillary non-perfusion area. But once we go to ultra-wide field imaging, you can see almost whole of the peripheral retina has been knocked off. And this patient, if not treated aggressively, we are going to lose this eye. Again, have a look at this particular patient, diabetic, non-proliferative diabetic retinopathy on conventional imaging. And you can see there are some CNP areas, some peripheral dot and blot hemorrhages. But once we go on to ultra-wide field imaging, you can see the patient has many microaneurysms which are present in all 4 quadrants. And once we go to the peripheral images, you can see there is a neovascularization which is present in the periphery. And with the help, so it is very useful to detect peripheral neovascularization, ultra-wide field imaging, which can be easily missed with the conventional imaging. And now these are 2 different patients with diabetic retinopathy. And this is what we had a conventional view of diabetic retinopathy, where the disease is limited to posterior pole. But with the help of ultra-wide field imaging, now we know that the diabetic retinopathy is 2 types, one which is limited to the posterior pole, and the other one where it is involving the periphery also. And now we know that the ones which involve the periphery are more likely to progress to proliferative diabetic retinopathy. Now, again, this is a very useful picture. If you see on a cursory looks, it looks like the patient has severe non-proliferative diabetic retinopathy. But if you carefully look, this patient has much more changes in the inferior retina, which is very well seen on ultra-wide field imaging. And this patient basically has non-proliferative diabetic retinopathy, and additionally has an inferior hemiretinal vein occlusion. And that is why there is stark difference between the superior and inferior retina. So the ultra-wide field imaging is useful for the exact localization of non-perfusion, quantification of non-perfusion. It acts as a guide to targeted laser therapy, and is also useful in the early detection of peripheral NVEs. Coming to vascular occlusions, now again, you see this is a patient with infratemporal branch retinal artery occlusion. And conventionally speaking, a BVOS study told us that anything more than 5 disc diameters of non-perfusion is considered as ischemic BRVO. Now, in this patient, what I try to do is mark the disc using a circle, and then I try to fit that circle in the non-perfused area. So if you see, I could fit in almost around 50 disc diameters. So this is markedly more non-perfusion what was given to us by study by BVOS. So now, with the help of ultra-wide field imaging, we know that the actual non-perfusion area is much more than is visible on standard or conventional photography. And in the setting of CRVO, which was earlier considered that 10 disc diameters of non-perfusion is non-ischemic, with the help of ultra-wide field imaging, we know that more than 75 disc diameters of non-perfusion is non-ischemic CRVO, and less than 30 disc diameters is non-ischemic CRVO. However, remember, there are no set guidelines till now for BRVO using ultra-wide field imaging. Now, have a look at this particular image. You can see a NVE, NVD, and a peripheral non-perfusion. Again, on a cursory look, it looks like diabetic retinopathy proliferative. But again, if you see, the posterior pole is almost quiet. The changes are all predominantly in the periphery. This is nothing. And very clear-cut and starking example of ocular ischemic syndrome, which involves the periphery and not the center of the retina. So again, this patient was referred to us with the diagnosis of central retinal artery occlusion. You can see there's almost no perfusion at the macula, and OCT showing the inner retinal hyperreflectivity confirms the diagnosis of CRO. But once we go to ultra-wide field imaging, you can see these triangular areas in the retinal mid-periphery. These are hallmark features of choroidal infarcts and are known as Amalric sign, and can be visible on fundus fluorescein angiography also. This indicates that this patient not only has central retinal artery occlusion, but also has choroidal non-perfusion, and this patient needs to be investigated on the lines of ocular ischemic syndrome. One more common disorder, again, Eales disease, very commonly seen. If you see, this patient has a massive shutdown of the periphery. This patient has undergone peripheral sectoral laser, but the neovascularization of the disc is persisting. The ultra-wide field fluorescent angiography shows us that there are some peripheral areas which are still unlasered. This patient underwent completion of the laser and the NVD promptly regressed. And subsequently, we published our findings also in IGO. Again, I want to highlight here that there's nothing which cannot be done with standard photograph. For an experienced examiner, everything can be picked up on IO and standard photography also. But a non-experienced person, it is much easier to pick on ultra-wide field imaging. And the main usage of ultra-wide field imaging or wide field imaging is better documentation. Now, again, just to show, this is a patient with FEVR. You can see the temporal avascular area, some exudation in the temporal retina. And once you do the fluorescent angiography, you can see there's massive neovascularization in the temporal retina. And this patient needs peripheral laser photocoagulation, or he'll be at a risk of tractional retinal detachment. Again, a vascular disorder, the large angioma. While large angiomas can be easily picked up with naked eye, the small ones can be easily missed if we do not carefully screen the whole retina. Ultra-wide field imaging is particularly useful because we can pick these lesions early, and the small lesions are the ones which are easy to treat. And once they become large, it is extremely difficult to treat these lesions. Now, again, just utility of wide field imaging, you can see this patient has a typical bulb-like dilatation seen on conventional photography as well. And you can see the exudation. This is a patient of adult onset coats. And once we go to ultra-wide field imaging, you can see a peripheral avascular retina. And nowadays, with the help of ultra-wide field imaging, we know that this avascular retina may be the reason of constant source of VEGF, which can lead to recurrence in these patients. And if you see, we can see the other peripheral lesions which can be missed with conventional imaging. Now, some patients with uveitis and RD, again, I'll be highlighting how it is important to document. You can see this patient who came to us with the decrease of vision in her left eye in second trimester. We cannot do fluorescent angiography in this particular patient. You can see well-defined whitish patches which are going almost up to the mid-periphery, and wide field autofluorescence shows that these patches are hyper-autofluorescence. This gives us the clue that we are dealing with a common disorder called mutes, which is not uncommon in pregnancy. And all we need to do is watch this patient, and hence this ultra-wide field imaging was useful for us in preventing us with going ahead for certain other investigations. A toxocaragranuloma, we have all read, we have all seen, but to document beautifully with the help of ultra-wide field imaging gives us a different kind of pleasure, because it is very easy to teach students as well as consult the patients regarding their conditions in the eye. Now have a look at this particular patient. This patient was a case of ALL, acute lymphoblastic leukemia, was referred with leukemic retinopathy. But if you carefully see, this is a patient with aggressive CMV retinitis, which is involving the posterior pole. And this patient, unfortunately, due to chemotherapy, was lost to follow-up. And with the help of ultra-wide field imaging, we can see how this CMV retinitis progressed and involved almost half of the hemiretina. Coming to RD and allied disorders, again, many patients come to us with the lattice degeneration, and we are not able to show them what is the condition in the eye. But with the help of ultra-wide field imaging, we can document these lesions beautifully and counsel the patients regarding the future treatment strategies. A patient with retinal detachment, and you can see there are multiple cysts inside the retina called retinal macrocyst. And this is something which with a standard fundus photography will not be able to capture, and therefore there is the utility of ultra wide field imaging to capture all these images. A patient with giant retinal tear, if you see the whole of the superior retina is folded onto the inferior retina. This patient underwent vitrectomy with gas, and you see the attached retina. And one advantage of Optos system specifically is that it is able to see even through the gas bubble. So we can see the retina even under the gas bubble, consult the patient. At the same time, we can document to for the better data generation for the research purposes. The last topic would be dystrophies. Again, this is something which is not commonly seen in our conditions, but in the clinics. But once you take ultra wide field imaging, the diagnosis is almost staring at you, and you can very easily make a diagnosis of pigmented paravenous retinochoroidal atrophy. On the other hand, if you get a single image of the periphery or the center, you'll not be able to make the diagnosis very easily. In fact, even in posterior pole dystrophies, something like Stargardt disease, it has been shown that ultra-wide field imaging, using ultra-wide field imaging, that even in diseases, macular diseases like Stargardt's, there is involvement of the posterior peripheral retina, and this can be helpful in the prognosis of the patient. Now, again, very rare disease. If you see on a cursory look, it looks like something called as retinitis pigmentosa, but very, very characteristic picture. If you see, there are well-defined areas of depigmentation which are surrounding the posterior pole and sparing the posterior pole. And there is schisis at the posterior pole. This is nothing but enhanced S-cone syndrome, very typical picture, which can be very easily diagnosed with ultra-wide field imaging. So to conclude, in congenital disorders, especially because these patients have poor vision, they have nystagmus, they tend to have non-dilating pupil, these conventional imaging modalities using conventional cameras can be very, very difficult. And using ultra-wide field imaging, we can easily monitor these diseases. A word about wide field imaging. Again, I'll just show you a case. This is an elderly male who came to us with floaters in both eyes. The vision was 20/40 in both the eyes. This is the wide field color photograph. You can see a large RP rip over here. This is the right eye imaging. You can see there is a large RP rip which is visible on fluorescein angiography as well as on ICG angiography. Now, if you carefully see in the left eye, in the supratemporal quadrant, there is a mound. So when we did the imaging of this particular patient, you can see the blocked fluorescence corresponding to the mound. And if you see carefully, you can see these peripheral polyps. So this is something, again, which can be diagnosed with the help of only ultra-wide field imaging. And this, we are dealing with nothing but peripheral polyps, or something known as PEHCR, peripheral exudative hemorrhagic chorioretinopathy. But everything has a flip side. Even wide field imaging comes with limitations, especially I'm talking about Optos here. Because it has red and green laser only, there are no two true colors. So the diagnosis can be challenging where the colors are very important, especially in patients with retinal and choroidal tumors. We are grading, striving to be better, but still we cannot get 360 view of the aura with a single click. But let me remind you that ultra-wide field imaging is not a substitute for indirect ophthalmoscopy. But a good IO with good indentation can give you the information ultra-wide field imaging can never give you. As the superior and inferior retina are not so well imaged with Optos because of the eyelash artifacts, and because it uses a ellipsoid mirror, there is considerable peripheral distortion, and the measurements of the peripheral retina tend to be incorrect. And the most important is the cost involved, and it may not be possible to get this machine in all kind of setups. A word about RETCOM. As it is a contact modality, it is very useful for following up the patients, pediatric patients, especially ROP. And I think REDCAM is something which is integral component of the universal newborn eye screening and telescreening of the ROP. A word about multicolor photographs. As I told you already, in conventional fundus photograph cameras, we have red, green, and yellow filters. But in Heidelberg module, specifically Spectralis, what we have is three lasers. One would be red, green, and blue. So they give us combination, something images called infrared reflectance, green reflectance, and blue reflectance. And once we combine these three images, we get something known as multicolor images. So these are nothing similar to color, normal color images, but remember, in color images, what we have is white light going in and white light coming back. So what we get is true color. But here what we get is three different lasers which go in independently, and depending on the structure they strike, they come back, and the images are recorded as multicolor images. But remember, multicolor photographs are different from pseudocolor images of optos, where we have only two lasers involved, red and green. Just to give you an example, I have already showed you many red and green images, that is pseudocolor images of optos. So to conclude, ultra wide field imaging is very useful because it is efficient. It helps us to capture the peripheral retina. It provides us very fast images in no time, and these are predominantly non-contact images. We are almost able to get all type of image modalities using ultra wide field imaging. It is excellent for documentation and monitoring of the peripheral retina and its disorders. And it definitely has provided us new insight into the peripheral retinal disorders. Thank you so much. If you have any queries, I'm always available at my email ID.
Thank you, Vinod, for this excellent talk on photography, basically. And because fluorescein angiography will form the next series of 2 lectures. So what Dr. Vinod has actually tried to cover, because 80%, 90% of his talk was on optos only, primarily, because he has large experience on that. So after listening to your talk, it makes us believe that without the optos, we are missing a lot of peripheral lesions. There's no doubt in that. You see that people who are not experienced in good indirect, they may miss out without the, but the beauty of photography, as you rightly said, not only helps in medical legal, but very good documentation and research and teaching and patient cooperation, such things are important. But a good fundus drawing, you see, my question to you was, people who do not have optos, you see, everybody does not have the luxury to work in RP center. And even in a lot of private setups, optos may not be easily available because of the cost reason also. So people who do not have, can, you see, with patient cooperation, you reach up to the vortex vein, and sometimes you see, with good cooperation, you can reach up to the wide field level, at least till the vortex vein. Beyond vortex vein, sometimes it may be difficult. And about the angiography part of it, long time back, when we were residents, we used to rely on fluorescein angioscopy findings instead of, you see, because we never had, we only had that 30-40 degree old Zeiss cameras, and we never had the luxury of these wide field cameras. So what is your take on that? Because cost is an issue and everybody does not have. So after listening to talk, people should not go back with the idea that agar optos nahi hai to retina practice nahi ho sakti. So you see, I agree with your first 2 slides, documentation, patient teaching, medical legal aspects, research component, because photography is objective, whereas whatever you see on FA or indirect ophthalmoscopy, that is subjective. Because I know a lot of old timers, you see, who have been our teachers, which they relied primarily on beautiful indirect diagrams, and which were true to the core and absolute all the findings picked up. So what is your take on people who do not have optos?
Sir, I think I try to put that point forward. in my conclusion slide that opto is something which cannot replace your good indirect ophthalmoscopy. It is not possible to have optos in every system. And I cannot, even if I go through literature, I cannot find a single new, I can say, lesion which has come up with optos. So it is not that it shows us something which is new. So it just helps us document the peripheral retina. So that is something for a novice, for a new person who is viewing the peripheral retina, it may be difficult to stitch every piece together.
Yeah.
But with the help of optos, it becomes easier. So technology is to make our life easier, but it is just not true that without it you cannot practice. You can 100% practice, and all the lesions which we could see have already been documented in clinical practice. Optos did not show us anything new. It's just that subtle finding which can help us manage our patient better. Those have been revealed, and it becomes easier for a new person. For experienced eye, it does not matter whether it is they have optos or not.
Yeah, the reason I wanted to reiterate these points, I know you mentioned in the initial slides of the last slide, is that these people who are listening and people who do not have optos, do not go back with the idea that all is lost. But the beauty of that is documentation. You showed excellent examples of diabetic vascular block, and you see that coronary infarcts, very beautiful slides. But documentation also is very good for the world to believe that what you're seeing is true. That is the beauty of that optos.
I think an analogy could be the maps of the world started being made in 1600, right? Yeah. And those maps were very accurate, right? Yeah. Actually, if you want to believe Hindu philosophers, then actually even thousands of years before. But then what you see in the satellite image of the entire Earth being one and how everything comes together, it looks very beautiful, So basically what the optos and other ultra wide field systems do is they put together in one field what you're otherwise seeing in multiple
fields. Yeah.
Now the question is, can I see those multiple fields? Yes. And I think Vinod said that very clearly. No doubt in his mind. But remember one more thing about this. When we talked about the conventional imaging in terms of 7 field and all, they were talking of 30-degree fields. Why? Because at that time, the technology was of 30-degree fields. There were some cameras available with 40 and 45-degree fields over there when they did the ETDRS study. But the general rule was to have 30-degree fields.
Yeah.
Most cameras had that. So they decided to go to the lowest common denominator. They picked up 30 degrees as the field, took 7 fields of 30 degrees to pick out as much area as was covered. Now, this is why you must remember the reason for taking that was because that was available. Nothing else was available. Now, the conventional camera is no longer a 30-degree camera. It is a 50-degree camera. So imagine what was first. So 30 degrees was looking straight ahead, looking up another 50 degrees. So actually you are anyway going almost 80, 90 degrees with some overlap. At least the 80, 90 degrees you are covering even now. And if the patient is very cooperative, even up to 100 degrees on each side. Which
I agree, because with patient is cooperative, till vortex vein, we do photograph. We do photograph.
Easily picked up.
Lattices and breaks, we always pick up.
Sometimes even cooperation. Yeah. So the point is, no one must go with the idea that you can't pick up those lesions without it. But one point, what Vinod said, and I like that a lot, you can make all the diagrams you want, but the picture is worth 1,000 words.
Yeah.
And that picture, which is photographic, is worth at least 150 words, if not 1,000 words. Because
what I liked about Dinesh was that because if you show the picture to the patient, that this is a normal retina and this is what your peripheral retina looks like, he tends to be more cooperative. Because if you tell him that this is the lesion in the periphery, like he showed, you see, diabetic retinopathy, all of us have been made to believe it's a posterior pole disease. It is mean majority, but peripheral lesions are also known. And if you show this to the patient tends to become very cooperative, apart from good documentation, and that increases the patient cooperation also.
Yeah. So
Rolika, you have questions?
Yeah. So actually, see, the thing is, the main role comes, would you pick something new? So the analysis of that showed that actually there are only 5% lesions which were de novo present only in the periphery, not in the center, so on fluorescein angiography, and which would affect the management of the patient, actually.
Very important, because this point is, suppose there are patients whom you have lasered conventionally. Okay, you on a cursory examination see that you have well lasered. He showed one example of NVG and PDR in the other eye. And beyond the arcade, there is huge amount of non-perfusion. So that, what Dinesh was saying, helps in the management. You see, nowadays, in such patients, we do not a conventional kind of PRP, but we will go beyond equator also in such patients. So
and
like
remember,
he said targeted treatment. So wheresoever there is non-perfusion, that is source of VEGF, and you have to laser all such areas of non-perfusion.
Again, understand, our conventional PRP was up to the equator because our lenses used to go up to the equator.
Yeah.
Okay. Today, you see, we know the ischemia is more in the periphery than the center. So why would we stop at the equator? Only because we can't go beyond it.
So therefore, we started doing laser with LIO.
Yes. So that is why. So the important thing is you must try to pick up as much of the retina as possible. Conventional photography helps you to document most of the lesions. An extra 10% lesions are probably there which go beyond, which you can visualize if you go with by asking the patient to look up, down, whatever. But still there be another 4-5% lesions which you can only see with conventional methods. But with ultra wide field methods, you would be able to actually document them.
Yes, we know you had some point.
Yeah, I think, sir, again, I try to make that point in the beginning, that what is standard keeps on changing,
Yes.
So as of now, 45, as Dinesh Talwar sir said, that earlier it was 30 degree and very few cameras had 45, 50 degree. Now universal is around 45, 50 degree of field in almost cameras. Yeah. So I don't see 10 years down the line why all cameras would not be 150 degree.
Exactly. So, you see, at that time when ETDRS came, 30 degree was the norm. So there's nothing like conventional or standard. These are dynamic things as the lenses keep evolving.
It's like we don't get those fat TVs now. There are no non-camera phones available now. So similarly, all these technology is going to be wiped out, sir.
So let's hear, let's hear to the questions, because I think those questions by the audience and the hot seats are more important for us to answer this. We have had enough discussion amongst ourselves.
Yes, sir.
So yes, Rolika, some questions from you or from.
Thank you so much for such a wonderful talk, sir. And the questions that we have are that what kind of lesions can be not picked up on indirect ophthalmoscopy, but can be picked up on good imaging?
I think his last couple of slides said that. Yes, Vinod, can you answer this again?
I think again, going by conventional teaching, when I say IO is just to screen the fundus to look what is the area of the interest. If it is peripheral examination, we are predominantly going to use IO. But once we have isolated our area of interest, then the most important way to go forward would be slit lamp biomicroscopy. See, IO cannot pick all the. Once you go, this is the area. Then we switch on to high magnification fundus imaging, or you can use slit lamp biomicroscopy. And I think I can't think of a lesion which will be missed on both of these modalities. By and large.
So the answer, Rolika, is these conventional examination techniques of IO and biomicroscopy will pick up all the lesions which ultraviolet field will not add anything to the picking up rate of the convention.
Only the documentation will be better.
Yeah,
you can't document on indirect, you can document on this.
So this is one part. The second part is As a matter of fact, I have a condition, something called choroidal hamartomas. So
Mhm.
these are typically seen in neurofibromatosis 1 patients, and you will not see them with any other imaging modality. But the moment you go to infrared reflectance imaging,
Yeah.
you will see that these patients have a lot of these nodules. So just to give you an example, but again, at postgraduate level, I would say almost everything can be picked up with our examination, and then we can use our imaging techniques to confirm our diagnosis
And document them.
and document them.
Yes, other question, Rolika, please.
So one question is that during a follow-up of a patient, how often would you like to document it like by fundus imaging? Like you're drawing the retinal diagrams for sure, but then how often would you like to document it by imaging?
See,
Depends on the,
documentation today is the hallmark. Believe me, it saves you, it helps you in research. Suppose you have done laser. Documentation to pre-operative or pre-laser, then post-operative, post-laser, post-injection, pre-injection. So they have to be done primarily so that the world believes in you. See, documentation is important, not only for research, but to tell the patient, teach the patient also. पहले lesion आपका ये था, अब आपका ये हो गया.
See,
So
the interval between two documentations would be dependent on the time it takes to have a significantly visible change in them. For example, if you're doing laser, we know it takes a minimum of 6 weeks for regression to occur. So you would, if I have to do, there's no point doing a photography every 15 days or a photograph every 1 month. So I would probably do it at 6 weeks to 2 months. I won't do a fluorescein angiography before 3 months. Because that's the minimum time it takes for a change to really become visible.
But in contrast to a giant ear, retinal detachment, you would do it earlier.
Yes. Now, on the other hand, supposing, for example, I have a patient who's developing a traction fold, and I want to see whether this is progressive or not. I may do it every 3 weeks or 2 weeks to follow up serially over a period of 2 months. Is it increasing? If it's increasing, I may want to do some interactive or some surgery for that. So depending on whether I believe that this can progress rapidly, slowly, regress slowly, fast, I will decide what interval I want. So it varies with different diseases.
Other question, Rolika?
So as you all have mentioned, that documentation is pretty important, and the postgraduates at the baseline level cannot really invest in a fundus camera, and many of the centers don't even have a fundus camera.
Yeah.
So what do you recommend as a baseline way of, or it's like for even for screening or anywhere for
a smart camera, a smartphone based camera, which at least takes 50 degrees. You ask the patient to look up and down and the sides to make sure you get at least 70 degrees. Beyond that, you only document by writing down whatever you saw on the indirect.
So answer is that if you don't have access to all these big cameras which cost in lakhs and lakhs of rupees, smartphone based cameras should be learned by everybody, and their stands and all are easily available in the market now and are very cheap and very easy to learn by these young colleagues. And if you have inertia for that also, then as Dr. D.T. Dinesh was saying, draw in the OPD file, on the file, and keep a record of this thing also, that you can make an indirect drawing, which last time Ritesh was telling us, that you draw and show this was before and this was after. That can be done. But believe me, smartphone are going to be future also. For people,
that's the beginning. You can't afford an Optos. You pick up
that's for people. That's for people who can't afford that.
2 lakh rupees to kar doge na agar tum practice start kar rahe ho to.
And for the postgraduates, they should know that it's very easy to just hold a 20D and hold your camera against it.
That is the first level. Your own camera with your own lens. That's the first level. The second level is the fundus camera based on a smartphone. That's around 2.5 lakhs. As you can afford more, you can go higher.
Right. So
you see, nowadays the Remedio cameras, and you see if this other companies are very cheap cameras nowadays, which are easily
very
affordable.
Good handheld holders, and they have been released with good apps also. I think postgraduates must explore those. It makes it easy for them to. So the questions from our end are over, and you may go ahead. And Dr. Soni, if you would like to ask any of the questions, you're most welcome.
Dr. Soni, Dr. Deepti, anybody, any question? But one thing I liked from Vinod's talk was clear clarity of initially only said difference between standard, conventional, and wide field very clearly. And secondly, that one slide of yours, which said that recently 2 years back when imaging people sat down and defined for us, itna ye in 50 degree, 100 degree, and beyond 200 degree. So this should be universally accepted, not a loosely used terms which you said. Like up to
one point I'd like to.
Please.
Vinod made a very nice presentation about the role of multicolor imaging, and multicolor imaging is not just to show various colors. The importance is to pick up various levels of the retina, and that is probably going to be the most non-invasive way of doing imaging. The Heidelberg, when it gives you the composite, actually it's of no use. What you really need is each of these single reflectances, the blue reflectance, the infrared reflectance, and the green reflectance, and you can pick up and actually tell the level of the lesion, the details of the lesion, and I think he showed that very beautifully. And that is something that probably needs to be explored much more than we are doing just now. I'm sure he must be doing it, and I'm sure we all need to do it. This is where the future lies. Would you like to expound any more on that, Vinod?
I think, sir, I again tried to show in the beginning that this was something which was available with our conventional fundus photograph cameras also. We had those blue, green, and yellow filters. And somehow we always underutilize them.
Exactly.
And something. And the problem with them is that you have to use individually in a particular patient to find where is the lesion. The only difference between this Heidelberg module is that it gives all of three simultaneously. You can use any of them according to your advantage. So that is the usefulness of.
I think the important thing is we need to do a little more of this and correlate them with what we see in terms of the disease entities, and we may get a better understanding of the pathophysiology going on.
So I think we would like to conclude this because time is up, 9 o'clock, and we follow the discipline of starting in time and finishing in time. But believe me, Vinod, your lecture has made us wiser, and because the importance of this photography, conventional, standard, wide field, ultra wide field, everybody is clearer. And the last word which I started with is that heavens are not going to fall if you do not have Optos. And Vinod also agrees, DT also agrees, everybody agrees that a good indirect drawings and what Dinesh said, where that a recourse to a low cost, handheld cameras should be the beginning. And after that, as you increase in name, fame, and this thing, you can acquire high-end cameras, and then maybe Optos, God willing, you can have Optos also. That's the way all of us progress. So with these, I think we would like to thank Vinod for crystal clear concepts he has given us. And this all this talk will be available at YouTube immediately after this talk. And thanks again to Santosh for conceptualizing this iFocus program. And we wind up with saying thanks to all the panelists and Rolika and the question answers by the audience.
And
thank you very much.
You,
and see you again in the next iFocus program that will be on Friday, and that will be starting with fluorescein angiography by Dr. Pradeep. That's again a very important topic. So thanks everybody, and bye till we meet.
Thank you. Thank you.
Thanks.